Well, good afternoon, everyone. My name is Michael Cinque, and I'm here to introduce our latest topic for our AMDA D to D web series. This is webinar number 9. Can you believe that we've been doing this since May of 2021? This has been quite a great run, and I hope that you've enjoyed the webinar so far, and we are very excited about our webinar today, optimizing the use of statins, aspirin, and antihypertensives. Now, there's a lot here, and depending on how this goes, we may break this up and take the antihypertensives into December, but we'll see how it goes. But one way or the other, we're going to be talking to you about all 3 of these categories, and we're excited. Next slide, please. Just as a reminder, because you've done this before, please, your participation is encouraged. These are seminal topics that we'll be talking about today. Please use the chat function. Next slide.
Done right.
Okay, and so today, our speaker is Dr. Kristen Zimmerman. She is an associate professor for the Department of Pharmacotherapy and Outcomes and Science at Virginia Commonwealth University School of Pharmacy. Kristen, I would like you to please take it away, and everyone enjoy the webinar.
Great, thank you so much. So I plan to give everybody sort of a mile-high view today, because I really will hope that y'all will lead the discussion through the chat box. I think that's really helpful to see what questions you're running into in your practice areas and how we might address them together as a team. So I don't have any disclosures relevant to the topic today, and I'm hoping that we can get through all 3. If not, that at least we can have a really rich discussion about the first 2, statins and aspirin. So I want to first start by talking about statin use and some of the sort of details about how we might think about optimization of statins in long-term care. So when we think about indications for statins or aspirin, we're typically thinking about 2 types of indications. We're either thinking about secondary prevention, preventing an already diagnosed disease from getting worse or recurring. So that can include past heart attack or stroke, in preventing a second heart attack or stroke in someone who's already had one, or preventing a heart attack and stroke in somebody who's at risk for having one. So for example, somebody who had ischemic heart disease, preventing their first heart attack or first stroke. So backing it up into what I had really hoped to take away for everybody is I think that the most important thing is thinking about, why is deprescribing in preventative care such a difficult thing for us to do? Why are these cardiovascular medications so prevalent? And I think it's really because when we think about the data that supports the use of these preventative cardiovascular medications, we're thinking about data that's based on community dwelling older adults, right? The guidelines are really founded in this scenario where these community dwelling older adults have a static, more favorable health trajectory in mind. That's pretty consistent. And so when we think about the patients that these guidelines are designed in mind with, it's patients with a pretty consistent life expectancy, a pretty consistent functional status, and a pretty consistent quality of life, right? And that may not necessarily jive with the patients that you all are interacting with in your practice areas. When we think about health trajectory in older adults, it's much more unpredictable. There are things that can derail or shorten somebody's life expectancy. So for example, we think about dementia, we think about life-limiting illness, we think about things that can derail somebody's functional status, thinking about frailty. And we can think about quality of life as being something that is somewhat tenuous and less consistent, and less static, and in some cases, less favorable, right? So the factors that impact decision-making and deprescribing in long-term care are different than they are when we think about community dwellers. So why is that important? it might explain why 1, 2, or 3 years ago, a patient, on a statin or aspirin, why that was okay and why that was appropriate, and why primary care, or why, the cardiovascular specialist, or why even the geriatrician on the outpatient side didn't discontinue it before they got to you. And so now you all have the opportunity, as this health trajectory has changed, to reevaluate that therapy and to decide whether deprescribing makes sense for these patients. So starting with statins and aspirin and thinking about our indications. Again, indications can be primary prevention, so preventing people from developing the disease; secondary, preventing an already diagnosed disease from getting worse or recurring. And so it may be important for you to think about differentiating between why patients in your care are receiving statins and why they're receiving aspirin. Is it to prevent an initial disease or event, or is it to prevent a secondary disease or a secondary event from occurring in a patient who's at risk for it? That might have implications potentially for how you might think about deprescribing and whether or not you think about deprescribing. Now, the caveats to that are that you may not have all of the pieces of information as to sort of why somebody is taking therapy. So good history taking can help, but we'll talk through sort of what do you do when you don't have answers to some of those questions and how might you conceptualize that decision. So I think it's helpful to think about the statin therapy recommendations as they relate to older adults. And the data as it relates to older adults is, again, largely focused in the community dwelling arena. I know y'all are in long-term care, but I think it's relevant to say that community dwellers with that sort of static favorable profile, even in those patients, the guidelines are very consistent that it is reasonable to stop therapy when functional decline, multimorbidity, frailty, or reduced life expectancy limits the potential benefits, right? So thinking about your patient population, those are patients who have functional decline, multimorbidity, frailty, reduced life expectancy that are limiting the potential benefits of statin therapies, particularly as it relates to primary prevention. All of these agents are really, their use is predicated on benefits first, right? So if those benefits aren't there or they're limited because of these other conditions, then it's a moot point. If patients are not going to be deriving those benefits, then it's time to think about whether or not we stop therapy. So in older adults receiving statins for primary prevention, largely as it relates to your setting, it's going to make sense to consider stopping therapy. Now, as it relates to secondary prevention, the guidelines tell us that it's reasonable to continue if someone's tolerating and if they have a low risk, quote unquote, of competing comorbidities, right? Well, I don't know about you, but your patient population probably has a lot of competing comorbidities, right? Things like dementia, things like chronic life-limiting illnesses. We can think about chronic end-stage heart failure, right? So your patients have frailty. All of these things that may be considered competing comorbidities where the risk to benefit ratio might shift, right? And so even the guidelines say potential benefits versus adverse effects should be considered in secondary prevention. So, okay, let's give that some clout. Let's say, all right, well, let's do some risk versus benefit evaluation. What does that look like? Well, when we think about the benefits of statins, we're thinking about things that are, again, in that sort of preventative space, preventing a heart attack, preventing a stroke, reducing somebody's cardiovascular or all-cause mortality. Great. But there are risks that shouldn't be minimized, things like an increase in liver function tests, dyspepsia, which is actually quite common, and an increase in muscle-related side effects. And the things that can shift the balance for some of those risks are things that are also relevant to the patients that you might see. So we think about older adults who are particularly frail, who have kidney disease or liver disease. Those are patients who are at a higher risk of developing statin-related side effects. And so it shifts that balance from kind of this like even neutral scale for older adults that you see here to really kind of tipping into those benefits are just not as robust and those risks are growing as we're aging. So, okay, you're still like, I'm not fully sold. Well, let's think about what is the time to benefit from when a statin is started to when a patient is going to derive benefits, that reduction in cardiovascular risk that we just saw. that time to benefit is a minimum of about 2 to 5 years. So compare or contrast that with what your patient's life expectancy or health trajectory looks like. Are they having a shortened life expectancy because of an exacerbation of a chronic life-limiting illness? Do they have dementia, where we know that the time from diagnosis to death on average for someone with dementia is about 8 years? Do they have something that impacts their functional trajectory over time? And we can expect a really robust functional decline to continue. Do they have a decline in their quality of life? Do these things match up? So what does the data say about statin discontinuation? When we look at data in long-term care in particular, we see that statin discontinuation is successful. It can totally be done, and it is sustainable. Statins that are discontinued largely stay off of patients' med regimens, so they don't get added back on. And in addition, what we see in statin discontinuation for those who have advanced life-limiting illness, we see that not only is statin discontinuation successful and sustainable, but it's actually safe. We don't see that there's any difference in somebody's overall mortality. So by taking away this statin, we're not, causing them to have an event necessarily or have a shortened lifespan because we're reducing that benefit to overall or cardiovascular mortality. We don't see that. We also see that statin discontinuation is associated with better care, improvements in quality of life, and of course, reduction in cost, though obviously that's not the primary driver. So as it relates to the evaluation of statin appropriateness, how can we sort of implement this in patient care? The first step is to check the indication. Is it being used for primary or secondary prevention? If it's primary, for the most part, there's not the same level of data, right, to support it if my patient's health trajectory, goals of care don't match with that. So the gray area is if the statin is being utilized for secondary prevention. So you can ask yourself, okay, it's being used for secondary prevention. What do my patient's goals of care look like? What is their health trajectory going to continue to look like? Are they really healthy, robust? They're here for a short-term stay and their disposition is to go back home where they're going to be community dwelling again? Okay, but I'd like to bet that that's not most of the patients that you are interacting with in your practice areas. Most of your patients receiving statins for secondary prevention have limited life expectancy, have anticipated functional declines over time, are frail, and it would not make sense in that scenario to continue statin use for secondary prevention. So we're going to consider stopping statins for folks who are in our facilities receiving these agents for primary prevention, or anytime it's not aligned with goals of care or health trajectory, and patients who have advanced life-limiting illness, risk for side effect, or short duration of use. And we'll see this in the case that we'll talk about today. If somebody has not already been on a statin and it's a relatively new start, and you're like, but they've been on it, I don't know. How long have they been on it? And what is that? How does that relate to their overall health trajectory? Are they going to be on it long enough to derive a benefit? Or is their health status going to continue to decline and it's essentially a moot point? So before we move on to aspirin, I do see a question in the chart about the statin discontinuation study mentioned. Was that primary prevention, secondary, or both types mixed? And it is both types. It did not differentiate by indication. So great question in the chat. And I see another comment. Let's not forget that statins, especially potent ones, have been shown to increase A1C. So we could argue, okay, statins also increase risk of A1C, but is that increase in A1C also a driver of somebody's overall health outcomes, their overall morbidity and mortality in your settings? Probably not, but a great point, Rohit. So moving on to aspirin use, you'll see that there's a lot of the same themes in aspirin as we were seeing in statins. And it starts by really thinking about what are the benefits versus risks. And again, the use of aspirin is predicated on this potential future benefit, right? And we don't have this crystal ball to predict, who's going to benefit in our settings and who's not. But we see that with younger patients, we do see that there is a benefit that includes a risk reduction for stroke, cardiovascular events, and mortality, coupled with a relatively low risk of side effects like GI bleeds and brain bleeds. But that calculus totally changes with aging. And we see that older adults have a notable increase in the risk for bleeding, driven by a number of risk factors, the biggest one being age, but also male sex, diabetes, smoking status, elevated blood pressure, concomitant NSAID use, and also really potentially prominent history of GI ulcer. So those are drivers of shifting that risk to enhance the risk of bleeding, which sort of offsets the dulling of benefits that we'll see that occurs as patients age. So this is a more salient discussion when you're thinking about an older adult in your facility who's a chronic faller, who may be falling and may be at a greater risk for developing a bleed. So again, the calculus changes a bit with age. So when we think about the benefits versus risks of aspirin in older adults, when it comes to primary prevention, the data is really quite clear. The risks certainly outweigh the benefits, so much so that the U.S. Preventative Services Task Force this past year updated their recommendation to recommend against the initiation of low-dose aspirin for the primary prevention of cardiovascular disease in older adults. So the data is very clear that aspirin for primary prevention in older adults is a no-go. So that's very clear. The data for secondary prevention, however, is again a little bit more interestingly gray when we talk about largely community dwellers, right? So, there may be some potential benefit there. When we think about the population that you are all interacting with, we'll see again that calculus changes. So what does that mean? So the time to benefit from the initiation of aspirin until when benefits begin is a minimum of 5 years. So again, how does that jive with your patient's life expectancy and anticipated health trajectory over time? When does this sort of shift occur as well? So when we think about the risk to benefit shift for aspirin, we know that the benefits decline with age. We also know that the risks increase with age. And we know that near age 75, the risks of aspirin use, those risks for GI bleeds and CNS bleeds, begin to outweigh the benefits of aspirin. We see that the number needed to treat and number needed to harm become very close together. And then the number needed to harm starts to exceed the number needed to treat. So the risks begin to outpace the benefits after age 75. So what does this mean for overall aspirin use? Similar themes apply. Checking the indication. If patients are using aspirin for primary prevention, we already know that the data says to stop. If patients are using it for secondary prevention, we also know that unless, again, your patient is that really healthy, robust, short-term stay individual who's going to be returning to community dwelling care, that for secondary prevention in somebody who has limited life expectancy, an unfavorable health trajectory, that's going to be a patient in who you're going to discontinue aspirin as well. So you all have met Mrs. Smith before. She's somebody I have not met before today. So Mrs. Smith is an 88-year-old female admitted to your SNF greater than 3 months ago for rehab following hip fracture. She's taking atorvastatin 20, which was reportedly started last year by her PCP, is taking aspirin 81. Neither she nor her family know how long she's been taking it. And she carries a diagnosis of dementia, hypertension, hyperlipidemia, type 2 diabetes, obesity, CKD, AFib, diastolic heart failure. So importantly here, preserved ejection fraction heart failure, CAD, arthritis, osteoporosis, incontinence. She also suffers from depression and anxiety. So one thing you'll notice that I tossed in here is her prognostic score. And I don't know if this is something that many of you use in your practice, but it's something that can be a helpful sort of reality check. When I don't have the ability to assess somebody's prognosis using a really robust calculator, sometimes I just ask myself, would I be surprised if this person died in the next year? If the answer to that is no, I wouldn't be surprised if they died in the next year. That's a bit of a litmus test in terms of how I might be perceiving this patient's overall health trajectory and life expectancy, and prevent my own bias about favorably wanting the patient to do well, let that get in the way. So her prognostic score, if we were to calculate her risk of 6-month mortality, her risk of 6-month mortality is 20%. So that's a pretty poor prognosis. So is Mrs. Smith receiving her statin and aspirin for primary or secondary prevention? So if anyone wants to plop in the chat, is she receiving it for primary or secondary? Secondary, yeah, absolutely, right? So secondary prevention based upon the fact that she has CAD, which is considered subclinical cardiovascular disease. So she is receiving both her statin and her aspirin for secondary prevention. So now we're thinking about the other intangible factors, right? So what does her health trajectory look like, right? Is she going to have continued static health trajectory, a stable life expectancy, stable functional status, and stable quality of life? Or do we anticipate that those things will continue to decline for her over time? Do you think she's likely to derive benefit? So I'm seeing not much benefit, decline. Yeah. So her health trajectory is very likely to decline over time, right? We know that she has dementia. We know that she has this 6-month mortality index of 20%. So again, limited benefit of statin because, as well as aspirin, because of her limited life expectancy and her anticipated both functional decline as well as overall health decline in life expectancy. So she is unlikely to live long enough to derive benefit from either statin or aspirin therapy. So at this point, it would be appropriate to discontinue therapy. So some things that you can think about from an operationalization of this perspective, right? We can think about, thinking about who in our practices is taking aspirin or statins for primary prevention, and that can be low-hanging fruit in terms of deprescribing. And then when you get to the gray area of thinking about secondary prevention, it's easy to think about some of these things that are very clearly mitigating or modifying somebody's risk, right? So thinking about secondary prevention in somebody who has concomitant dementia. It's thinking about deprescribing these agents in somebody who's taking them for secondary prevention who has a mortality index that is low. So there are ways to sort of objectify the relatively subjective decision of whether to discontinue statins or aspirin in patients like this. So I see a comment from Matt in the chat. Our residents have tons of comorbidities like Mrs. Smith. The statin use, I think, is very often secondary. Any guidance on what disease states are safer to deprescribe? Example, history of stroke versus recent stroke versus CHF, CAD versus others. So great question, Matt. There has been some data looking at statin deprescribing as it relates to cardiovascular events. It's largely been in the community dwelling space. And some of the themes that we pull away from that is that folks who are taking agents for secondary prevention who have a variety of cardiovascular comorbidity, so say concomitant hypertension, concomitant diabetes, there are some risks associated with stopping in those patients over a period of time. So generally over a period of 3 to 5 years, you might see that some patients have an increase in cardiovascular outcomes. Now that sounds really scary, right? Until you put that into context of over a period of 3 to 5 years, and you think of the number of patients that would need to have a statin deprescribed in order to have an event occur, and that number is really quite high. And so when you're thinking about that risk moving forward, we have to maybe accept that for every 127 people who are taking statins for secondary prevention in whom we stop them, if they're community dwelling, one might have a heart attack or a stroke. But let's offset that with a patient like Mrs. Smith. What is her life expectancy like over the next 3 to 5 years? Well, she's not going to live those 3 to 5 years to see that increase in risk following discontinuation. So in some sense, it's really patient specific and relative to that, getting back to that idea of health trajectory over time and someone's life expectancy. So some more questions in the chat. Can you start a statin for secondary prevention in someone who is never on it? So great question. And it would again depend on the patient. So the data for secondary prevention in somebody who's never been on it, it is reasonable to consider initiating either a statin or aspirin for secondary prevention if, and only if, like big capital letters, bold red if, it matches with your patient. So is your patient going to be discharged to home, community dwelling, functionally independent, and they're staying with you for a short-term rehab stay? In that scenario, it might make sense. So that would be a different or more specific scenario for your patients. So let's see what else is coming up in the chat. Over 75, aspirin use questionable. Absolutely agree. Patient goes to cardiologist, comes back with aspirin and statin. Family trusts cardiologist. Suggestions. There's actually some really rich data on the interplay between the specialist, the cardiologist, the general provider, and how folks communicate with patients about deprescribing and where that deference sort of comes into play. One thing that you could begin with is thinking about putting in perspective for the patient and the family member, what are the goals of care? And thinking about some of the likely scenarios. What is the likely scenario and the unlikely scenario? So oftentimes I'll use, numbers like, I would have to treat 100 patients who looked like you over 5 years to prevent one of them from having a heart attack. That kind of language can be useful in the patient discussion. But I would also encourage you, if you're able and you have the bandwidth, to connect with the cardiologist. I think this presents an even more robust opportunity to reach across disciplines
Hey,
to
Kristen,
provide some of that education and prevent.
I've got to jump in here because you just nailed it with this last comment. I was just going to say the best success I've had in this scenario is just simply pick up the phone and call, because so many times cardiologists have told me, thank you so much for this perspective. I was just seeing a patient in the context of seeing a patient, and I was just following a recommendation. Thank you for adding this perspective. And I'm telling you that how many cardiologists change their course of how they're managing the patient because of that one phone call you make. So I just want to jump in because that's my favorite comment so far. Like, let's create a teamwork. Let's just call these providers. They shouldn't be doing their work in silo. So thank you for saying that.
Yeah, when we look at the data on, what are the barriers to deprescribing, which, you folks might have talked about in an earlier call, by far and away, one of the top reasons for inertia is lack of education and lack of knowing what to do next, right? And so sometimes it really just takes that conversation about the context of the whole patient as well, that may be out of the context that the cardiologist has, right? So when you think about specialty care, you're really thinking about a single organ system focus. I think as the care team in long-term care, or like a primary care team, you have a different perspective of the holistic view of the patient and their health trajectory. And that's helpful information to share with providers and to discuss some of the data about the risks versus benefits as they relate to that patient, and build that relationship, provide that opportunity for cross-disciplinary education. So there was a comment, a question in the chat about the prognostic score. Yeah, so I love to use eprognosis.ucsf.edu for a lot of my prognostication decisions. And you may also find it to be a helpful tool in your practice as well. So Rodney asked, do you have links for these studies? Yeah, Rodney, I'm going to post an updated slide deck that has citations on the relevant slides, and a reference slide that'll contain some studies that you can use if you're looking to sort of build an intervention or have discussions with providers. Yeah, so all right, great. Other questions in the chat? We're right at the precipice of antihypertensives at 5 o'clock. Yeah, Sabina, ePrognosis does have specific data for nursing home patients, which is where the data for Mrs. Smith came from. And that's looking specifically at risk of 6-month mortality. So great. So we're at 5 o'clock. Do we want to try to get through top line of antihypertensives?
Yeah, I think you're pulling it all together. That would be awesome.
Okay, cool. So antihypertensives, the story of letting go of going low. We are told time and time again, as it relates to blood pressure control and blood pressure care, that lower is better. And that's consistent with what our guidelines for community dwelling older adults have said over the years. The data has consistently supported these studies where blood pressure goals are creeping down, down, down. Now, the problem for you all in long-term care is that, well, this doesn't include your patients. Your patients haven't been included in any of these sentinel studies that are showing that lower is better. So what does that leave the long-term care provider to do in terms of targeting blood pressure goals? Well, let's look at where that sort of risk versus benefit trade-off is. So if we look at levels of systolic blood pressure control relative to risk of harm, or what we can consider mortality, in just different age groups. So not even thinking about somebody with, chronic life-limiting illness, for example. What we see is that for younger patients, those age 60 and under, high blood pressures are bad, associated with increased mortality, right? And we see that low pressures are good in these younger patients, associated with lower mortality. And that's where the idea that we saw on the last slide of lower is better sort of comes from. But that's not necessarily true when we think about older adults in their 70s and older adults in their 80s. And these patients, what we're seeing is that low blood pressures can actually be bad and associated with increased mortality and increased harm. And some of those risks are due to medication-related risks like hypotension, orthostasis, leading potentially to falls, different electrolyte disturbances and acute kidney injury, or decreased perfusion to critical organs like the brain, the heart, and the kidney over time. So it might be due to the drug, or it might be due to the fact that the pressure is just so inherently low. Now, on the other end of the spectrum, we also see that high blood pressures are really not so bad, right? We do see an increased mortality, but not at the same level that we see with younger patients. So what does this mean for older adults? It really means that we're trying to find the right range, right? That we need to be cognizant that we're not too high, we're not too low, we're just like Goldilocks and the Three Bears, and we're right smack dab kind of in the middle, right? And so it's really kind of thinking about this window that falls somewhere between 130 to 150. Now, really important caveat here, this is the level that we are treating to, right? So your patient may have an inherently lower blood pressure than this, not on any antihypertensives. That's not what we're talking about here. We're talking about somebody who has clinical hypertension, who is on medication therapy to reduce their blood pressure to a certain level. That ideal window is about 130 to 150. Not only are we trying to find this window, why is this window so important? We know that there are risks associated with overtreatment of blood pressure in long-term care in particular. In this setting, we see that blood pressure is outside of that window, under 130, on 2 or more antihypertensives, is associated with higher mortality, an 81% excess of mortality compared to somebody who had a higher blood pressure or who was not on 2 or more antihypertensives. So overtreatment can result in worse outcomes for your patients that you're seeing in long-term care. So it's really important to think about de-intensifying blood pressure regimens in these patients. So again, younger, community dwelling, healthy, robust adults, we consider these sort of lower goals. When we're thinking about frail older adults, we're thinking about our oldest old, 80 and older, we're thinking about folks who are institutionalized, we're thinking about a systolic blood pressure goal under 150, right? But remember that a goal is more than less than. It's also thinking about staying above that idea of too low, right? So that ideal window around 130 to 150 is where you are treating towards. So what does that mean for antihypertensive deprescribing? We know that antihypertensive deprescribing in long-term care is not associated with a change or a decrease in overall blood pressure control, and actually might have some favorable outcomes. One other evaluation of deprescribing in older adults on multiple antihypertensives that I want to point out for an interesting reason, they used a very structured medication discontinuation algorithm, and they cut out first any antihypertensives that were considered to be potentially inappropriate. And we'll talk about what kind of some examples of that might be. Then they thought about any antihypertensives where it was just like, man, not great risk to benefit data. And then they went with diuretics, ACE inhibitors or ARBs, and calcium channel blockers intentionally in order of where do you get your most bang for your buck, right? And that's where that sort of order came from. And following this structured discontinuation algorithm, they saw, again, no decrease in blood pressure with deprescribing one antihypertensive, no serious adverse events or changes to quality of life, but blood pressure increased by a whopping 3/2 millimeters of mercury. Big deal, right? So putting it in perspective that it is safe and well tolerated. Now, the other really cool thing that these trial researchers did is they compared by drug classes, like what happens when we stop these. And what they found was that discontinuing the beta blocker was pretty well tolerated. Real no change in blood pressure outcomes, easy to do, makes sense. Blood pressure lowering effect of beta blockers really aren't that robust. And then it was really well tolerated. People stayed off of it. And so if we have an opportunity to deprescribe a beta blocker, it might make sense to prioritize deprescribing a beta blocker. Now, on the other end of the spectrum, stopping someone's calcium channel blocker was associated with a bit of a decrease in somebody's blood pressure control. Kind of makes sense because these are amongst the most potent drug class for blood pressure lowering, and less likely to be maintained or stay off them over a period of time. Doesn't mean it's not worth trying, but it just means that if our goal is to keep blood pressure exactly where it is because it's perfect, then maybe we think about discontinuing the calcium channel blocker last. If, however, our patient is like grossly overtreated and their blood pressure is super duper low and we need to get that up a little bit, that's where stopping a calcium channel blocker can work in your favor. You want blood pressure to rise, right, in that case scenario. So bear that in mind as you think about what agent you might pick off first. So what we see, it's not inherently harmful to discontinue. We might consider discontinuing potentially inappropriate antihypertensives, followed by beta blockers if they're not used for another indication next, and followed by calcium channel blockers last. So I really like this structured med algorithm. So it might be something you find useful. So here's, though, the spoiler alert. There's a huge caveat to this, and it's the fact that antihypertensives are used for a whole variety of other things besides blood pressure lowering, right? So certain drugs have additional benefits like heart and kidney protection, maintaining heart rate in someone with AFib, right? Reducing progression of heart failure over time in certain conditions, right? Things like diabetes, reduced ejection fraction heart failure, atrial fibrillation. So we need to make sure that we're adjudicating why is somebody taking this antihypertensive before we sort of put it in the bucket of being discontinuable, right? So thinking about the MedRec process and the medication history taking and the medical history taking will set you up for some success here when we think about these blood pressure agents. So I'm not going to go into this table in detail. This is for your reference, but it highlights some classes of antihypertensive agents and some common examples, some other indications that these drugs and drug classes might be used for. So these would be the things that we would say, okay, well, that's not being used for hypertension. I can evaluate the appropriateness of it for that other indication, but right now I'm thinking about de-intensifying somebody's blood pressure regimen. I'm going to skip over that one. This table also lists the common side effects that you're going to want to potentially be alert for in older adults, as well as other considerations for older adults. So I mentioned, meds that are potentially inappropriate in terms of antihypertensives. Two of these classes of agents are non-selective alpha-1 blockers, things like terazosin, centrally acting alpha agents like clonidine are considered potentially inappropriate in all older adults and on the Beers criteria. So those would be things that you'd want to knock off first if you could. This table also outlines which medication classes require a taper, which would be another consideration in the implementation phase of deprescribing. So what does this mean? Checking the indication is the number one thing to do because some antihypertensive meds are used appropriately for other conditions. Number two, identify overtreatment. So is somebody sweetly between that, 130 to 150 range, or are they way below that? Is their systolic 110, 118? Well, that's overtreatment. Or overtreatment can also be considered taking 2 or more antihypertensives. That would also be considered overtreatment and a potential case scenario to deprescribe. Assessing for medication-related side effects. And in that case, you're thinking about active side effects, makes sense to discontinue. Somebody's dizzy, somebody has pedal edema, or potential side effects. So you might be thinking of, wow, this patient has had a couple of recent AKIs. They aren't having an AKI right now, but they're at risk for an acute kidney injury. Maybe I want to rethink this medication, this antihypertensive that puts them at risk for having another AKI. So it's thinking about current side effects, but also potential risk for future side effects. Another pearl that I often consider is discontinuing the low-hanging fruit of low-dose agents. Something's on a starting dose, And there's, multiple agents where there's other room to enhance therapy elsewhere, I'm going to get rid of the thing that's at the starting dose, right? Because if blood pressure goes haywire, I have room to optimize blood pressure with another agent that's on board. And then also the consideration of taper. So before we get to Mrs. Smith, I do want to head back to the chat. How do you feel about patients who have blood pressure on the low side, under 130 systolic, but occasionally have higher blood pressure? I'm often at a loss with these patients. Remember that blood pressure is a dynamic thing. It's not always constant and it's not always perfect. So it's thinking about, on the whole, what is the proportion of your patient's level of blood pressure control? What are the things that are associated with it being too high or too low? Are there errors in measurement, times of day that it's being measured relative to somebody's medication taking? So a great example might be somebody taking a short-acting multi-day clonidine that they're supposed to be taking 3 times a day, they're taking 2 times a day, and it's wearing off. And as the drug's wearing off, their blood pressure is going up. But then when they take the clonidine, an hour or two later, their blood pressure is tanking. And so they're on this roller coaster. Well, that is probably because they're on a medication that they shouldn't be on, and there may be another opportunity to enhance a different antihypertensive or get that medication off if it's causing them to have that roller coaster, which we know is more harmful than being either too high or too low. So hopefully that sort of addresses your comment, Sabina. And then Bob, I'm going to get to your the pedal edema in just a second with our case of Mrs. Smith. So Mrs. Smith, who we've met earlier, right, is taking carvedilol 6.25 twice a day, losartan 25, amlodipine 5. We've talked about her history. Her systolic pressure is 118. Her diastolic is 68. So she falls outside of our range. She denies dizziness, but reports swelling in her ankles, pedal edema. And we've talked about her prognostic score. So do any of her antihypertensives have another indication of value? Well, yeah, right. We could look and say, well, is she taking carvedilol for her AFib? Is that what she's rate controlled on? Well, I wouldn't want to discontinue her carvedilol if she's not a normal sinus rhythm and needs to be on her carvedilol for her AFib. Or is she on carvedilol for her history of coronary artery disease? She could be taking losartan for diabetes and her history of kidney disease, and she doesn't have another indication for the amlodipine. So that helps us put into perspective at face value, like, well, we probably aren't going to touch the carvedilol unless she's having a hard time with it till we know more about her AFib. But let's look at her losartan and her amlodipine. So consider her systolic blood pressure. Is she being overtreated? I would argue, yeah, right? So she's on 3 medicines. Our threshold's really 2 or more, and her systolic is 118 and our window is 130-ish to 150-ish. Does she have any potential side effects? Yeah, pedal edema, right? So the swelling in her ankles could very well be due to her amlodipine, right? So we want to make sure that we're thinking about potential side effects there. And so which medicine would you consider discontinuing, when and how? So for her, because she's having an active side effect and because she's overtreated, this is a scenario where I would feel comfortable discontinuing the amlodipine first. Because she's having a side effect, she's got plenty of room with her systolic blood pressure. If it does increase by 3 or 4 points, great. That's what we want, right? So in this scenario, I would agree with discontinuing the amlodipine first. Secondary to that, yeah, so Sandra, you brought up the great point of losartan may also have benefit for diabetes and CKD. Sure. So what is the time to benefit of that ARB for her diabetes and CKD? How does that mesh with her overall health trajectory, life expectancy, and continued functional decline? Well, if her 6-month risk of mortality is 20%, she may not really be deriving as much benefit from continuing that losartan as we once thought she did. So if she needed further reductions in her blood pressure medications, it would make sense to think about targeting that losartan. That losartan is in a very low dose, 25 milligrams. And so it would make sense to consider pulling that back. Now, there's additional pieces of data that we don't have for her, such as her electrolytes, that may, again, change your calculus a bit. And again, I would probably keep the carvedilol on board until we had more information. So I want to make a lot of room for questions and discussion. I don't know what kind of time we have left.
We're actually at that point. So are there any other questions in the chat box at the moment?
I don't see any more questions.
No.
Just a few comments.
Yeah, so Kristen, I cannot thank you enough for this unbelievable talk that you gave to us today.
You're too kind. Sorry for the slide snafu. You all are very patient with me.
Please, I think Arif nailed it. We've all done it. Thank you so much. And for everyone else, I would like to thank you for joining us today. Is there another slide below this?
There is.
Great. Please nominate a Choosing Wisely champion. There is the link to nominate your center or people for Choosing Wisely. You've been through this process with us since May of 2021. You're ready to do this, so please consider this for your organization. Next slide. And then to know that our check-in will be November 17th, and our final webinar for this year will be on December 15th, where we'll do a recap of what we've gone through since we started our D2D program in May of 2021. So with that, I will wish you thank you, and have a great evening, and we look forward to seeing you in November. Kristen, thank you so much.
Thank you.